Hi, everyone, and welcome. All participants have been muted. If you have questions or need technical help during this call, please utilize the chat function in the bottom right corner of your screen. You can also private message me or Leandra Lacey, as who's serving as our technical assistant, and we're also listed as a host. All questions for presenters will be addressed at the end of the webinar, but we will keep a queue, so please send them our way as they come up, and you can also enter them into the chat box. This webinar is also being recorded and will be uploaded onto the NCSC's website and YouTube. The recording and presentation slides will also be emailed to those that registered. These materials will also, same thing, sorry. So today we're having the Providing Partner Services During COVID-19 Pandemic webinar. My name is Desiree Smith. I'm the Health Equity Manager at the National Coalition of STD Directors. I'm joined by my colleague, Leandra Lacey, NCSC's Associate Director of Capacity Building and Member Engagement, who is facilitating technical assistance, as I mentioned before. A few things about our objectives. Our main objective today is notifying partners of exposure and also ensuring partners receive necessary screening and treatment. As the COVID-19 pandemic has hit our field, we've noticed a significant change in the ways that STD programs and DIS provide partner services and their respective programming policies. To highlight the innovative work that DIS are doing to ensure those exposed to an STI receive the best possible care and prevent the spread of COVID-19, NCSC is hosting a webinar that explores clinical protocols, telehealth, online partner notification, and COVID-19 safety measures in the midst of reopening phases. To begin our webinar, we have the lovely Zant Bryant from Washington State Department of Health.
Uh-oh, I think that means I'm on. Hi, everybody. If you cannot hear me or if I seem too quiet, please speak up and let me know. I have a tendency to be soft-spoken. I'm Zant Bryant. I work with the Washington State Department of Health. And I'm going to be working on making sure I get these slides moving. Desiree, how do I do that? Because I am struggling with that right now.
They're in the bottom left corner where the arrows are.
Okay, use the arrows. Thanks very much. Okay. So let's see if I can get that to work. There we go. So who am I? I'm the Infectious Disease Public Health Program Advisor for the Washington State Department of Health Office of Infectious Disease. We're an office that works across multiple integrated syndemic approaches to respond to the epidemics of sexually transmitted infections, HIV, and hepatitis C. Partner services is just one piece of what we do and what we support. In my position, I am the principal investigator for our federal STD grant, as well as a DIS. I step in and work cases regularly, and I also provide support, technical assistance, and training to disease intervention specialists and to STD and HIV prevention programs. So I'd like to revisit briefly a little bit about partner services, just to center for some folks how I'm looking at this and why I'm walking through it in this order. Partner services is at its core a biomedical intervention in which we are working to identify people who are infected or at risk and intervene in the spread of disease through primarily a delivery of medication so that we can either conduct secondary intervention to cure existing disease, which we'll talk about, or even better, abort incubating infection, which is primary intervention and our top goal, because that's what stops the spread is, for example, getting bicillin in butts, to be quite plain about it. So that means we have to begin with passive surveillance data for HIV and sexually transmitted disease cases, which is consisting of lab reports and provider case reports, so that we can then conduct active surveillance, get out there in the community and find cases that would otherwise not have been identified by the medical care system and reported to us. That means we have to get to a point, in spite of COVID, where we can interview the infected and the affected, whether that's the original patient, partners, or others who may be at risk, and to identify additional people at risk and ensure that they get correct treatment for diagnosed infection or exposure. And of course, we always want to connect patients to follow-up care or supportive services so that hopefully we don't see them again because they have services at their disposal, I should say, to support better health outcomes and to support them in better sexual health and drug-using health. Okay, with that in mind, we got to start with a case report. And in Washington, we're a little bit weird because in order to consider it a case, we do require both a lab report and a case report. And those are reportable to us within 3 working days. And the more rapidly those cases are reported, the sooner the intervention and the spread of disease can begin for us. Unfortunately, that is heavily affected by the coronavirus pandemic because of its demands on staffing and changes to procedures. That timeline gets lengthened. Medical providers and their staffs are already hugely overburdened without COVID-19 in the picture. They already have 84 different priorities on their plates, and STD and HIV, whether it's reporting or testing, might not always be the first one on their list. This timeline gets lengthened when their procedures get changed and people and what they're doing with people is more complex and takes longer. And that means that the chance we get our hands on that case quickly have dropped to some extent. That is also true for our lab partners, many of whom are overwhelmed with coronavirus testing. For example, our state public health lab had to move their HIV and syphilis confirmation testing work to a second public health lab at Public Health Seattle and King County as a backup so that the state public health lab could deal with the overwhelming crush of work to be able to assist in the coronavirus pandemic. And that also changed things for us to an extent as well. So knowing that lab capacity and provider case reporting are affected, that's one part of it. The other side is we'd like to get additional information from the provider, preferably beyond what's in the lab report or the case report, that's going to support partner services investigations. We're nosy. We want to know a lot about our patient and what situation is that surrounds them testing positive for example, syphilis. So sometimes that takes a call to the provider. If we have electronic medical record access, that really helps us get around this, helps us be less of a demand on providers and their staffs when we're looking for this information. But if you don't have it, sometimes that has slowed me down as a DIS because I've been trying, and that's slowed down other folks in our state as well, because we've been trying to get that additional information that's going to help us conduct a better partner services investigation. Because the first thing that we've got to be able to do in order to even identify people to notify of the risk of infection and get them into care is to get that interview. And so getting from the diagnosis to the interview can be a little bit of a struggle for us. Once the case and lab are reported, there's also, the pieces of matching those pieces of data up and making sure that they get into the appropriate data system, which for us is the Public Health Incident Management System, or FIMS for short, because everybody loves an acronym, which is our homegrown data system. The folks who enter the cases and conduct that passive surveillance, a lot of them have been drafted into COVID-19 response as well, especially at our smaller local health jurisdictions, but even in some of our larger ones, because this is an all-hands-on-deck situation. So staff redeployment for COVID-19 has meant that process also has gotten slowed down a bit. Staff redeployment for COVID also means that we have had to reorganize our work. I will point out that normally we would do a much broader selection than what you see there. We actually ended up developing, along with some other project areas, a tiered approach based on how much staffing you have available to you to work the cases in front of you. And what you see here, primary and secondary syphilis and women with positive syphilis serology, new HIV diagnoses, congenital or perinatal cases, those are the top tier. When you have 25% or less of your staff in play for HIV and STD, we determined these to be our top priorities for HIV and STD intervention, primarily guided toward prioritizing our top opportunities for primary or secondary intervention with symptomatic syphilis cases, and prioritizing our best opportunities to reduce community HIV viral load, as well as to prevent congenital syphilis or perinatal HIV. Once we get more staff back, which we've started to finally do in these last several weeks, then we're able to do other cases and add those to our prioritization, such as early latent syphilis or gonorrhea cases, for example, or cases of STD diagnosed cases of these types that are diagnosed in people living with HIV who maybe are virally suppressed. But we have to prioritize our top opportunities for intervention based on the amount of staff that we have available to us. I will point out, though, even though a lot of things fall out of that prioritization, most of your syphilis reactors and a lot of your HIV reactors still require work to resolve how they fit into the prioritization in the first place. I know a lot of places have dedicated surveillance staff who do this type of investigation for you, that surveillance investigation, to see that. When I worked in Texas, for example, we had dedicated surveillance staff in our department who did that. In Washington, in a lot of cases, it's DIS who are doing that surveillance investigation. So that also weighs on how much time we can put into some of this priority casework. I will also point out that in Washington, you may or may not realize this, a lot of people think of Washington as blue state utopia in some cases. Washington is a polka dot state. Our politics are very, very different depending on the region of the state, and that means that reactions to the COVID-19 public health response have been extremely variable. And because COVID-19 has heightened the overall awareness of public health surveillance activities, that means it's been publicized, or rather politicized, by some of our public officials. That can change how people respond to public health intervention in their lives. As it is, there is significant public distrust of governmental public health. And there are good reasons for that historically, some of them very recent, when we talk about whether it's the effects of the Tuskegee project, or whether we talk about how government response initially was to the HIV/AIDS crisis in the 80s and 90s. There are a lot of people who have very good reasons not to trust what we do. This only heightens that for them and broadens it for some other folks. And so that has, I think, slowed us down in some places or changed how the public responds to what we do, even though COVID-19 contact tracing is very, very different from what we do. And I would say that the depth of investigation that we perform in HIV and STD, and the way that we perform it, and the way that we're able to intervene and spread can be very different from what COVID-19 contact investigation looks like. When those two get associated by people, that mix can sometimes be poisonous. The other thing that pops up is scams, where people just don't trust, and this is something we've dealt with before, but I think it's been heightened. I've run across it more working cases more recently than I used to, but people think that your call to them is a scam. I've certainly had some really interesting texts recently in response to my outreach to get in touch with a patient with some excellent strings of expletives. I'm sure we've all been told to screw ourselves by members of the public if we're DIS. We're used to it. It's just a little bit more common. But when I get people on the phone, I find myself having to explain who I am and what I do and get them to trust me a little bit more. It's been helpful to have a way for members of the public to verify who I am, because I need to verify who they are, but they also need to trust in who I am. That's a two-way street. And with that in mind, I'm easy to find if you Google me, and that's what I tell them. Okay, great. You're already on your phone. Why don't you go ahead and open a browser and Google me? If you Google me, you will find me, and you'll see that I'm legit. Not everybody may have that, but I think that that's something that's been very helpful just lately. Another issue we're facing in reaching people, whether that's for interview or for notification of exposure, is that there is a lot of instability emerging from the effects of the coronavirus pandemic. Major social determinants of health are being affected by that instability and really undercutting our ability to find people because folks have lost jobs, lost income, had to change their personal situation, whether that's living or relationship-wise. And so, for example, we have people, I've spoken with folks who have moved home due to the pandemic, sometimes across the country. And so I have to do a little bit more effort to, for example, track down information, whether that's with medical providers or via ICCR, about what they were diagnosed with in other places to find out, again, even just in a surveillance investigation situation, whether or not they fit into our prioritization or even need our services or public health intervention. Folks have had to move because they've lost income, so they lose their housing or even may lose their cell phone or may not have minutes as often as they would because they can't pay for it. And people also lose access to their health care because, unfortunately, our healthcare system is largely insurance-based. Although I did have a case where it kind of worked in the reverse way, which was unexpected. I worked with a syphilis case where the fellow lost his job, and that made him eligible for public insurance again through the state of Washington. And he got into the doctor right away based on that because he wanted to get on PrEP, and he knew that public insurance paid for it at 100%. So PrEP got cheaper for him when he lost his job, which is a little bit strange sounding, but I think that just demonstrates the weird complexity of our healthcare system and what it does to people. I will also point out that we've had to significantly reduce or eliminate field work. Washington, whether you realize it or not, is a large state. Some of our DIS cover large regional areas in which driving to meet your patient can be a multi-hour trip one way. But even with that in mind, our larger urban counties, such as King, Snohomish, and Pierce counties, which are all the Puget Sound metropolitan area counties, or among them, I should say, those are also the size of small states, and in some cases have the populations that are larger than some small states. And so even within those counties, distances and traffic, for that matter, can be prohibitive. So Washington has always been a place, or has long been a place, where we've done a lot of work by phone, which might be jarring for some folks from other areas of the country. And I can say, coming from places like Texas and Nevada, I definitely found it jarring at first, but it can be productive. You can still get a lot done by phone. And so we do. But when we're coming into looking at field work, because we would like to get back out in the field and be able to do field work as well as outreach testing, because we have some case clusters that we need to resolve, we have to think about COVID-19 exposure fears for both the DIS and the patient. We're at risk, but so are you. Testing isn't always available to everybody right on the spot, and we can all be asymptomatic. So we have to think about that risk and what risk we may pose to, for example, newly diagnosed people living with HIV who may or may not have immune system issues, depending on where they are in the course of disease. We also think about, again, the joys of our healthcare system. If we give a client COVID-19, whether they're well-to-do or not, and they become very sick, we may be burdening them with lifelong healthcare debt. That is not going to help their life be better and healthier. I've additionally seen a number of studies that suggest that drug use has increased during the pandemic, where people using drugs were already increasingly a large proportion of the folks that we work with, because the disease profile for us in Washington has changed when it comes to syphilis quite a bit, and we've also seen clusters or outbreaks of HIV among people who use, especially folks who share needles. So locating people who use and are unstably housed was already hard, or harder than locating many of our patients. It helps when we can urgently jump on cases before their information changes, because we all know somebody might have minutes today on that phone, but they might not have it tomorrow. They may have that phone number today, but next week they might have lost that phone, or it might have been handed off to someone else or stolen. We have a long-running bit of humor that in some of the counties that we work with, everybody shares one phone, and we're not sure who has it this week or if they've got minutes. So add coronavirus to that, where people are significantly affected by economic issues from coronavirus or instability in housing or relationships, and that becomes more complex. Facebook Messenger has been a very helpful workaround for that. A lot of this group are users of Facebook Messenger to communicate, and although we can't talk about protected health information through Facebook Messenger, we can at least set up a time when we know they're going to be someplace where they've got their phone or another device, and they have Wi-Fi, and we are at least able to have some conversations. And that has helped us still find people and refer them for healthcare, and find cases of disease and get them tested and treated. So I think that's been a very helpful workaround for us. But the interviews, they also change in a pandemic. Again, we've talked about how suspicious folks are about public health. So we have to continually emphasize and reemphasize confidentiality to get through some of those distrusts, as well as be clear and transparent about what we're doing and why we're doing it. Another thing I've run across is a little bit of fear of judgment. There's been a tendency on the part of folks to judge folks who maybe aren't isolating during a pandemic. I think we're all human and have a tendency to do that. And I think some folks have been reticent to discuss who their partners are if they've been particularly active during a pandemic, although I did also have some patients who, bless them, they were more than happy to roll through that phone and share with me who they thought their contacts were. So it could be both, but I did experience some people who we kind of had to work through those gaps in their exposure periods, and address what was causing a gap in an exposure period. And in some cases, I've had somebody say, yeah, I was isolating. It's not like I was getting laid. I wasn't seeing anybody. But other people have, it's been everything from, well, I was in jail, my partner was in jail, or, well, actually, no, there are some people in that period. So you have to address it and see what the story is. And then when we're coming to notifying people of exposure, all these same caveats apply, plus then we have the issues coming back to healthcare of what COVID-19 does to our healthcare facilities. In Washington, we only have two standard STD clinics in two of our largest counties. And so we rely heavily on the healthcare system to assist us, and especially on our partners in sexual and reproductive health that you would think of as family planning partners. So, for example, our Planned Parenthood partners, some of our community health center partners, and local health jurisdictions that have small sexual and reproductive health operations. They've been indispensable for us where we don't have STD clinics, but they've had a lot of challenges in operating and keeping their doors open during COVID-19. In some cases, they've closed a number of facilities and concentrated their services in one place, which makes it harder for our patients to get there. In some cases, they've had to reduce hours or change how they're seeing patients. All of those things can lengthen the wait for someone. When that waiting room environment or flow significantly changes, patients get uneasy just in the change in what they expect. But also, even worse than that, when you're dealing with a population of folks, if you think about people who use drugs, for example, many of these folks are not well-to-do. They didn't grow up knowing our healthcare system well. Going to the doctor is not an experience that they grew up with or were trained by society to have. And healthcare to them is going to the ER in many cases, or to an urgent care. Waiting when you use, and it's an unfamiliar situation, it's stressful, is already difficult, especially if you're approaching a need to fix. The healthcare system also doesn't treat people who use well as it is. A lot of times it stigmatizes them and treats them as less, because the healthcare system is made up of humans too who have judgments, and that drives people away from medical care. Adding that to a lengthened wait and unease around changes in how waiting for medical care hits, that makes it much harder to get folks in. I worked with a young gentleman who was diagnosed with syphilis in an ER in one county but lived in a different county, and just trying to get him into a walk-in clinic that really wasn't all that far from his place, but still had all of these challenges ahead of him. I think it took us 4 times to get him treated, because he kept leaving before he could actually be seen for a number of these reasons. And meth only exacerbated that issue for him. So getting just to somebody getting tested and treated within a facility, rather a challenge with COVID-19. We usually get around that by providing testing or medication in the field. But again, field testing and outreach are really, really limited right now. We're only just coming back to being able to think about that. And so we're walking through, how do we meet the social distancing guidelines for this? Can we provide services outdoors where we know the risk is lower? And here in Washington, we're moving into the wet season. The rain is going to start any day. And when it does, in November, for example, our average rainfall in a lot of places is around a foot. So it's not like there's big gaps in the rain a lot of times. So providing these kinds of services outdoors becomes a challenge. And we have to think through that, as well as thinking again about our risk to the public and their risk to us, and looking at, for the state field services folks, for example, where we operate in different counties, we got to look at the local county guidelines and where those counties are in their reopening process, as well as what guidelines they put forth on how they think that people providing services should operate. And then there's the challenge of nailing down personal protective equipment. PPE is necessary, and there's new PPE beyond just, gloves that we would typically use. It's a challenge to get that stuff from suppliers, and we're having to look at how we get that through multiple suppliers. So that is another issue that we're facing, getting back out into the field. And that walks me through the steps for us around providing partner services to folks in COVID-19. I'd like to turn it over to my colleagues from, I believe, Philadelphia for the next installment. Thank you for your kind attention. That's our state flower, by the way, West Coast rhododendron.
Thank you, that beautiful flower. Next up, we do have Christine, and correct me if I do say this incorrectly, Arietta from Philadelphia Department of Public Health. 1 second, get you unmuted. Okay, your line should be ready to go, Christine.
Okay, thank you. Hello, everyone. My name is Christine Arietta. I am with the Philadelphia STD program. I am the field operations manager for the program. I started a few years ago as a DIS worker and worked as a DIS worker for quite a while. I have worked on a few special projects within the program, and I was a frontline supervisor for a few years, and just about 5 years ago became the field operations manager. I oversee the entire field staff, which include the frontline supervisors along with the DIS workers. Tony Gerard will be presenting with me today. I'll let Tony give a brief introduction.
Good afternoon. My name is Tony Gerard. I am a CDC assignee, and I've been in Philadelphia for roughly 20 years, and I've been in public health for about 30. Currently, I'm a specialist project coordinator, and I am responsible for managing staff who are responsible for reconnecting patients back to their provider who are HIV positive.
And out of all the programs that Tony has worked in through the years, Philadelphia
is an awesome program.
And is the best program. Okay, so we'll get started with our presentation. So right now, we are just going to give you some information on how we handled partner services during the COVID-19 pandemic in Philadelphia. Okay, during this presentation, the main topics we'll touch on are how we are notifying patients of positive test results, how we notify partners of their exposure, and how we are ensuring partners receive the necessary screening and treatment. So just to give you a little bit of background how our program works, there are two different classifications that we have patients in. Patients fall either under a priority category or a non-priority category. Now, prior to COVID, the non-priority patients were patients who tested positive for gonorrhea and chlamydia, and some syphilis and HIV patients. With syphilis patients, these patients would be patients who have a positive RPR low with a low titer, and previous HIV patients. And prior to COVID, the type of activities that we would complete with these patients were not as intense as they are for priority patients. So, for example, we ensure that when the record is assigned, when the patient is assigned to the DIS workers, we make phone calls, mail letters. In some situations, we complete field visits to these patients. And in addition to that, for our non-priority syphilis and HIV patients, we conduct interviews, and those would either be in clinic or face-to-face. And usually within about 3 weeks to a month, if contact has not been made with the patient, we would close that investigation out. As far as priority investigations, patients that fall into this category are those who test positive for syphilis and have a titer of a 32 or above, and our new HIV patients. In addition to that, any pregnant person, regardless of their diagnosis, is considered a priority investigation within our program. So with priority investigations, we complete multiple phone calls and field visits in addition to mailing referral letters. Field visits, how it differs from non-priority investigations is that we do a lot more field visits at different times throughout the day for priority investigations, and this can include early morning field visits, which is the field visits that occur usually around 7:30 a.m. We do late evening field visits in addition to weekend field visits. So this was all prior to COVID, and this is pretty much, just a quick snapshot of how we proceeded with these investigations before COVID hit. So in March of this year, the COVID pandemic hit, and as a result, we had to alter the way that we investigated all of our patients, not just priority patients, but and non-priority patients, just anyone that we came in contact with.
During this time, Pennsylvania took on a phase process which includes color codes. Red for stay at home, yellow aggressive mitigation, and green aggressive mitigation was lifted. So as a result, our program, we felt that it was prudent to actually modify our priority and non-priority cases. And also during this time, we had staff who were reassigned to address COVID, who were responsible for testing at the Lincoln Financial Center. So we were actually running with a skeleton crew during this time. So the city had an initial red phase, which was the most stringent in March. It included workplace restrictions such as essential businesses, hospitals, police and fire, and the health departments were mainly open. Congregate care and prison restrictions was in place, and all the schools were closed. Child facilities were also closed. And in terms of social restrictions, there was a stay-at-home order was in place. Large gatherings was prohibited, and only travel for life-sustaining purposes was authorized.
So during the red phase, the STD implemented guidelines on how we would run our investigations, both for non-priority investigations and for priority investigations. So in regards to the non-priority investigations, we stopped all field visits. If the patient had not responded within 2 weeks of assignment, the DIS would submit the investigation to their supervisor for further review and closure. As far as gonorrhea and chlamydia patients, we offered a telemed option. So rather than have patients come into our clinic, the clinicians that we work with in our STD clinic provided the telemed options, and medication for these patients were called into their local pharmacy. In addition to that, for those patients that needed to be interviewed, all interviews were completed over the phone, and all re-eyes were completed over the phone. For our priority investigations, if contact had not been made within 1 week of assignment, the DIS would discuss the investigation with their supervisor to determine what the next steps would be. Now, with these types of patients, pregnant patients were the only patients where a field visit needed to be completed. Again, all original interviews and re-interviews were completed over the phone, and in general, pretty much similar to the non-priority investigations. If there was no response from the patient within 2 weeks of assignment, the investigation was closed. Like Tony mentioned, during this time, more than half of our DIS staff were assigned to COVID. So we had staff that were working downtown in the commissioner's office, making phone calls to positive patients and also doing some contact tracing. And we also had DIS and management, for that matter, that were assisting at the drive-in testing sites. So like he mentioned, we had less DIS workers in the field conducting these investigations and, trying to get our patients in for treatment, testing, and completing interviews.
Okay. During the yellow phase, there was an ease of restriction which occurred in June. During workplace restrictions, businesses had to follow safety orders. Congregate care and prison restriction was in place. Schools had to remain closed. Child care facilities open, compliant with guidance. In terms of social restrictions, some stay-at-home orders were lifted for aggressive mitigation, implementing social distancing, which was primarily 6 feet. Large gathering of more than 25 individuals was prohibited.
So once we moved into the yellow phase, our program, pretty much as far as non-priority investigations, were pretty much the same as it was during the red phase. We didn't do too much as far as those patients. We continued to not do any field investigations during this phase on non-priority patients, and all interviews and re-interviews were completed over the phone. As far as the priority patients, during the yellow phase is when we started allowing staff to go into the field on some priority patients, mostly PNS cases, priority and secondary syphilis cases, in addition to the pregnant patients. Also, we continue to do original interviews and re-interviews over the phone. Now, I do need to mention that during the red phase and yellow phase, with the stay-at-home order being implemented in the red phase, and some for the yellow phase also, we did allow DIS staff to work from home. So if they were not assigned to work clinic that day, which means our STD clinic is in the same building, same floor as the DIS staff, which is pretty convenient. So every day we have a team of DIS workers along with their supervisor who are scheduled to work clinic in case patients come in and test positive during their clinic visits. So we need to ensure that we have staff there to interview them. So during the red phase and part of the yellow phase, if DIS staff and their supervisor were not assigned to work clinic that day, they were allowed to work from home.
During the green phase, this restriction was removed, and was removed July of this year. Workplace restrictions, businesses must follow safety orders. Congregate care and prison restrictions were in place. schools subject to CDC and Commonwealth guidance, childcare facilities open, complying with guidance. Social restrictions, continue the social distancing. Citywide mass order was in place, and large gathering of more than 250 people was still prohibited.
As far as non-priority investigations, during the city's green phase, we still continue to not have any field visits during this phase for non-priority investigations. And mostly the reason why we decided to continue not having DIS go into the field on these patients is so that they can, have more time to focus on the priority investigations. During the red and yellow phase, a lot of medical facilities were closed. So during that time, a lot of testing, didn't occur. But now that the city, not now, but over the last few weeks, since the city phased into the green phase, more restrictions were relaxed, and so more facilities were opening, more testing was happening, so more cases of syphilis, HIV, what have you, were being assigned to staff. So in order for them to be able to work those investigations effectively, we decided to continue the relaxed protocol on non-priority investigations, which again, no field visits required on these patients. Interviews are completed over the phone, and within 2 weeks of assignments, if we did not make contact with the patient, the investigation was closed. As far as priority investigations go, during the city's green phase, most investigative activities resumed, except for entering patients' homes. So all priority investigations are back to the way it was pre-COVID. We're doing face-to-face interviews. We're going to facilities to meet with patients at their appointments to complete interviews. We are increasing the number of field visits that we're doing on these patients and things of that nature. Now, as far as field visits go, we do require that staff take certain precautions while they're in the field. Of course, when speaking with patients, they need to maintain a 6 feet distance. And at the time of a field visit, if a DIS encounters the patient, at which time it's determined an interview is needed, what we have instructed the DIS to do is obtain the patient's phone number, inform the patient that they would call them from their car, and then the DIS would go to their car, contact the patient, and complete the interview that way. The reason why we have the DIS complete the interview in their vehicle while they are at the patient's home is, sometimes patients do give wrong phone numbers, or, in a situation where a fake phone number was given, for example, if the DIS were to come back to the office, make the phone call, find out it was the wrong phone number, they would have to drive back to the patient's home to address that situation. So we just have them complete it while there. So if there are any issues, they can go back to the home and speak with the patient again. Also, if a patient needs to be transported, at times patients have no means of transportation to get to our health centers, so we do offer rides to our patients. If a patient does need to be transported, we do require that they have a mask on. Each DIS also has a few masks that they carry with them while they're in the field in case a patient does not have one. We also provide the patient with a pair of non-latex gloves to wear while they're in the vehicle being transported. Patients are also instructed to sit in the back seat of the passenger side of the car, and we have the DIS use a drape sheet where the patient will be sitting. And while they're being transported, the windows should be down or cracked. So during this time, we've also, as a program, we also implemented travel protocols for our staff. So when staff are requesting time off, we do require that the supervisors check to see if where the staff is traveling to is considered a hotspot, a red or a high risk state. If at the time of their travel that the place where they're traveling to is a hotspot, then those DIS are, or any staff for that matter within our program, whether it's DIS, high school screening staff, management, whoever it is, if they travel to a hotspot, once they return to Philadelphia, to Pennsylvania, New Jersey, or Delaware, they have to quarantine for 14 days. Any international travel, regardless of where, what country staff are traveling to, they must quarantine for 14 days upon their return to Pennsylvania, New Jersey, and Delaware. And the reason why we have Pennsylvania, New Jersey, and Delaware as the states is because we have several staff that live in each of these states.
Just to quickly touch on our clinic practices, our rating room initially seated probably about 30 to 40 people, but currently we have roughly maybe 10 people who are able to come in. So what was done was we had staff remove a lot of chairs and stack them to the side, so they actually have someone who regulates the door and to ensure that there's a minimal amount of people in the rating room at all times. And as was mentioned earlier, telemedicine was in place, which I think was great to assist patients who didn't have to come to clinic. Mm-hmm. We have staff in our clinic who they must wear masks at all times to ensure that we minimize any transfer of possible infection. And we have a negative pressure room for patients who are actually positive or patients who display symptoms. And we use a negative pressure room to actually speak to patients and to address their concerns.
Just to give you a visual, we're missing one of the slides. Go back to one. Oh, sorry about that. Well, we had so those were the clinical practices that have been put in place. As far as DIS, for DIS who are working clinic and who have to speak with patients that test positive in our clinic and have to complete an original interview, before COVID, we have designated interviewing rooms that are rather small, just two chairs and a desk, and you're sitting pretty close to one another in those rooms because they're so small. Because of COVID, so the picture on your left is what our interviewing rooms look like and what we use when we're not in a pandemic. Now that COVID is here, we decided to use one of our conference rooms for DIS to complete their interviews on patients. And so as you can see, pretty standard conference room, and we do instruct the DIS to sit on opposite sides of the table when speaking with their patients in order to maintain at least a 6 feet distance. And this table is about at least about 8 to 10 feet apart. And
I think this is our last slide, but I want to quickly mention that in Philadelphia we do Chalk Talk, and it was pretty much done once a month. And it was in person, it was in a conference room, it was roughly 25 to 30 people who attended Chalk Talk, and this is a time to assess the case, actually to showcase a case and to go over just the structure of the case and allow staff to ask questions. And if the person was stuck and couldn't move further on with the case, they would get suggestions from other staff members to move the case along. And since COVID, we've been doing a virtual Chalk Talk, which I think was unique because I don't think it's Zoom, but we used I can't remember the name of the software that we used.
Teams?
It might have been Teams, Microsoft Teams. And with that, we have staff. They sit at their desk, and they actually are able to observe the person presenting online, which I thought was unique. And we kind of, we really take Chalk Talk seriously because it's a time to really share information and to, again, help cases along. But we continue to do Chalk Talk in Philadelphia, even though it's virtual, and we will continue to do so until further notice.
And that's pretty much it for our presentation on how we've adapted to COVID-19. I will say that, this is definitely an eye-opener. It allows you to, because of what happened, there are different ways where we can do things. And, once our country gets back to normal, we may continue to implement some of these protocols that we've put into place during this time. But only time will tell. And that's pretty much it. Thank you, everyone.
Perfect. Thank you so much to all of our presenters today, Zane in Washington and Christine and Tony in Philadelphia. We really appreciate the time that you took to craft these presentations for us today. My name is Leandra Lacey. I'm the Associate Director of Capacity Building and Member Engagement for NCSE. Before we jump into the Q&A with Desiree, I'd like to make you all aware of the DIS Slack workspace that NCSD has. Slack is the communication platform for NCSD's DIS community of practice, where you can chat with DIS from across the country. You can share resources. We have different channels for topics all the way from field safety to technology and partner services. So you can use that platform to continue any of the conversations going on today. If you'd like to join Slack, you can use the link that'll be in the slide deck, or I can put it in the chat box as well for you to easily access. And if you have questions about Slack, you can email me. I'll put my email address in the chat box as well. So just wanted to say that before we questions. I'll hand it over to you, Desiree.
Awesome. Thank you, Leandra, and thank you again to all our presenters for their presentations. Now we'll be taking questions from our presenters from the chat box, and you can also feel free to submit questions if you haven't done so already. I know that we had a question earlier from Leah. Hold on one second while I pull it up. Leah Casanave, sorry if I say that wrong, asked, how are folks accounting for shortages of STD testing kits? So if we are referring partners in for testing, but a lot of our testing sites are only testing if individuals have symptoms. And that is open to any one of our presenters to answer. And you can also answer this question in the chat box.
I'll go ahead and jump in. This is Zant. Well, we have been aware of shortages of supplies for gonorrhea and chlamydia testing, but our primary lab partners have not indicated that that has affected their ability to actually conduct the testing that we contract with them for. So up to this point, thankfully, it has not affected us, but that doesn't mean it hasn't affected others in the community or in the country.
Awesome. I know Tracy Peterson-Jones also asked this question, and I saw that a few people did answer it already. So if you have any further comments, definitely you can add them now. But Tracy Peterson asked, if you're providing HIV home testing kits due to COVID-19, how have your programs provided partner services?
I want to give a shout out to Cheryl.
Yeah.
I was going to say I want to give a shout out to Cheryl Radloff in Vegas who answered that also, and I encourage other people from other areas who aren't us to answer too.
So if anyone would like to answer this question, you can just press *#, and that will unmute your line from Adobe. And also, if you have your line muted on your cell phone or a phone, you can press unmute there as well. So star pound if you would like to unmute yourself and answer Tracy Peterson-Jones' questions about if you're providing HIV home testing kits due to COVID-19, how have your programs provided partner services? And again, that's star pound. Thank you for your question, Chris. I see that Chris Borger is asking, how are programs reacting to providers conducting more telemedicine visits and the possibility of primary and secondary syphilis cases in terms of what are considered priority interviews? So 710s, 720s, and 730s, how are your providers, how are programs reacting to the providers doing those kind of visits through telemedicine?
I can jump in on this one. This is Zan from Washington. In Washington, our STD clinics are still, and our sexual health clinical partners are still definitely prioritizing symptomatic syphilis testing and treatment. So whenever someone says that they have symptoms, they're actually encouraged to come in. But we do have a lot of folks in the medical system across the state who do testing and treatment but don't do a physical exam. So we already have been dealing with this prior to COVID, where providers don't really do the exam that helps them to report a symptomatic case, and we come across discussions of the symptoms sometimes with the patient instead of reported by the provider. Or there's, of course, the other joy where the provider did an exam at a previous appointment and noted and took down information about what were obviously secondary or primary symptoms to us, but that they didn't test for at the time. But I'm not bitter.
Thank you, Sarah. Just as a last question before we wrap up, we on the NCSD side, we're wondering, how do you engage clients who are experiencing homelessness? And again, if you'd like to answer that question, all you have to do is press star pound on your phone and then make sure that you locally unmute it by pressing your unmute button.
I think for us it depends in part on what kind of homelessness the person is experiencing. there are various forms of not necessarily having a home. There's the couch surfing format where someone maybe doesn't have a permanent home but does have some places to stay that are familiar, versus folks who are living rough, and for whom shelter is a much harder to come by thing, although I think there's a lot of flexibility and people go in and out of those phases. Our primary way of contact, we still rely on the contact information we're given to locate them in terms of telephone or potential address that they may have given, or an emergency contact. We also look for them on Facebook and attempt to reach them through Facebook Messenger. And then in the field, we're still going to be looking for them in places that we know to look for them or that others have indicated that they might be, and to reach out to shelter partners and people who provide services to folks who are living rough, as well as our folks who serve people who use, like our needle exchanges, for example, or substance use providers, to search for information that helps us track them down. And we're also going to, because so many folks who are homeless have been justice involved, we also double check with our criminal justice system to make sure that they haven't been picked up within one of our jails or our prison system at some point along the way or recently, even while we're looking for them. I don't know if that's very helpful or not, but that's some of what ran through my head.
Thank you so much, Dan. And very last question, Christy asked, how many of your DIS are redeployed to COVID-19 response and contact tracing, if any?
In Washington, it was the vast. Oh, there you are.
Sorry.
Go ahead.
Sorry. In Philadelphia, during the red phase and yellow phase, so we have about 13 to 14 DIS workers, and I'd say about 7 to 8 of them were working COVID-19. But since we've started our green phase and our as of July 1st, all the DIS workers are actually back full-time doing STD work. And part of the reason for that is because Philadelphia created a COVID division and actually hired staff to just, focus on COVID-19 response and contact tracing. So I'd say from about March to June 30th is when we have when we had half of our staff working COVID.
For Washington, it's been variable, but the vast majority of our DIS have been pulled into contact tracing work at both local and state levels. Our state team is a team of 7, and at one point we were down to 1 DIS and 1 supervisor out of a team of 7 and 2 supervisors that were not deployed to COVID contact tracing. Most of our local health jurisdiction teams in our larger counties, the vast majority of their teams were also deployed into contact tracing. We, too, at the state of Washington, have a whole new COVID office now. And the other thing that I think programs are experiencing is that in some cases, folks are getting hired into those COVID offices out of the STD and HIV teams because obviously there's a natural fit in terms of skill.
Thank you. So I would like to say thank you to everyone for joining today, and thanks again to our great speakers for their time. I'm asking everyone to complete the evaluation after the webinar. It should automatically open in your browser once this webinar closes. In order for that evaluation to then inform our future webinars, again, the recording of this webinar and slides will be sent out to all those who registered, and it will also be on the NCSD website, which you can always just search it via the name. And yeah, thank you everyone for joining. See you next time.